अभी लाइव नहीं ना है?
नहीं सर, अभी नहीं है।
हो रहा ना नेट तो नहीं रुको
सर अब परमिशन दे सर, लाइव करता हूँ, 6 बज गया सर।
ये वाला
ईयरफोन लगा।
अभी देखिए तो आवाज कैसी है?
हाँ अब सर बेटर है सर। तो सर बी रेडी सर।
बेटर है।
हाँ सर, at the count of 3 sir, I'll make this webinar live, or we'll wait for just 1 or 2. I'll update the attendees status. 1, 2, 3. Yeah, webinar is started. So sir, we'll just wait for a few minutes. Let some attendees join. They are live. Fine, sir. 20 people have almost joined, so we'll start. Good evening, everyone. My name is Kunal Gaurav. I'm Regional Manager of JV Chemicals and Pharmaceutical Limited. I welcome all the viewers across the region who have spared their valuable time on Sunday evening. As you know, sir, today's our guest speaker is Dr. V K Jagnany. Dr. V K Jagnany is one of the renowned and most respected doctors amongst cardiologists and nephrologists in Ranchi. Talking about our speaker, Dr. Jagnany has done diploma in cardiology and nephrology both. He is the founder, president of Jharkhand IACC. He is the executive member of Jharkhand RSSDI. He is the member of many esteemed associations such as FJCCI, ESCBI, CSI, Indian Thyroid Society, Indian Association of Prevention and Social Medicine. He was the organizing chairman of IACC Con 2016, which was the 7th National Conference of IACC. He is the specialist in treating heart failure, hypertension, diabetes, lipid and thyroid. So, sir, on behalf of JV Chemical, I welcome you, sir, and I hand over the session.
Thank you so much. I am humbled by the introduction that you have given. Let me share the slide. Is the screen visible?
Yes, sir. Yes,
Is
sir.
the screen visible?
Yeah. Yes.
Lights are changing?
Yes, sir. Yes. Everything is.
Okay, fine. Shall we begin?
Yes, sir.
Fine, thank you. Today we are here to talk about newer approach towards treatment of diabetes. We have been treating diabetes since ages, more than a century, but we always aimed at the numbers, the fasting glucose level, the post-sprint glucose level, the PPG, the FBG, and then the HbA1c. But is it only the numbers that is important? Is it only the glucocentric thing which should be taken into account when we are managing diabetes, or we should treat the patient rather than the numbers? Let's see what we want to say in these slides. Well, historically, if we see, we began the treatment of diabetes almost 100 years back with diet control, low in carbohydrate, rich in fat. Then came the insulin, then the sulfonylureas, then the bigotinides, and then there was no more new drugs. We were playing with these three molecules, and we were treating diabetes, and we were facing so many complications associated with it. We did not have anything to tackle the complications or prevent them. We were just trying to treat the blood sugar levels. Then in last 20 years, we have come up with some new molecules, the DPP4 inhibitors, the SGLT2 inhibitors, the glitazones, the alpha glucosidase inhibitors, the GLP-1 receptor agonists, and so on and so forth. And this is not limited only to management of diabetes. These molecules have helped us to understand that there is something beyond the management of diabetes, the comorbid conditions, the complications which may occur due to diabetes, and can they be prevented with these molecules? If we see in last so many years, it's not only the diabetes, but also the cardiac management has changed, starting with sulfonylureas, then biogonadides, then alpha glucosidase inhibitors, then thiazolidinediones, then glinides, then alpha 1 receptor agonists, then DPP-4 inhibitors, and bile acid sequestrants, then dopamine receptor molecules, then coming to the cardiac molecules, the adrenergic neuronal blockers, then central alpha 2 agonists, then beta blockers, then alpha 1 blockers, then calcium channel blockers, ACE inhibitors. So many drugs have come up, and we are using these combinations in managing hypertension, diabetes, heart failure, and looking forward to the various micro and macrovascular complications, which how and when can be prevented is the need of the hour. When we look at the fasting and PPG, along with that, we also look for the consistency of the treatment, the durability of the molecule, the HbA1c level. Is the molecule causing hypoglycemia? What about weight reduction? Is it there or not? Is particular molecule helping in weight reduction or not? How well the molecule is tolerable to a particular patient? What are the cardiovascular safety profiles? Can it be used in so many combinations which we have with ourselves? We have to take everything into considerations. So these molecules, do they have complementary action to each other? We look forward to it. Are we achieving a better glycemic control? What about the weight reduction? How about the disease progression? Is are we able to delay the progression of the disease? What about the long term complications? So glycemic variability is one new thing which we talk a lot about it. Glycemic variability, we mean to say that what about the changes in the blood sugar levels in a particular patient during the different times of the day, different times of the day or week or month. We do not want a glycemic variable. Sometimes he is getting into deep hypoglycemia, sometimes it is hyperglycemia, though the HbA1c remaining same. So we are looking for so many parameters. We are approaching the patient in totality using these molecules when we are managing diabetes. As the new molecules have come up, we are looking forward to the management of diabetes along with the heart failure, which is one of the important complications of diabetes. So we have changed our approach from glucocentric to cardiocentric to treat the patient in totality. We manage the blood pressure along with it. We use the antihypertensives. We go for statins. We emphasize on lifestyle modification, weight reduction, simplicity in diet. We want to prevent the cardiovascular and renal events which may occur along with the HbA1c reduction. So we are taking care of both the cardiovascular complications, the microvascular complications, the macrovascular complication, along with the mainstay, that is management of diabetes. So this is how the things have changed over a period of time. So we take care of retinopathy, neuropathy, peripheral artery disease when we were talking about glucocentric approach in management of diabetes. When we talk of cardiocentric, we take into account the stroke, myocardial infarction, heart failure, and the nephropathy. So a totality of treatment has is the mainstay of present day treatment in diabetes. The capture cross-sectional study, which has been done recently across 13 countries in established cardiovascular disease adults with diabetes. The patients were during their regular visit to the primary or specialist care were put enrolled into multinational cross-sectional non-interventional study with a primary endpoint to take care of overall cardiovascular disorders, the prevalence, and what about the diabetes associated with this. The post hoc analysis explored the various differences in different ethnicity in terms of age, gender, the clinical parameters about the cardiovascular prevalence. It was understood that worldwide almost 1/3 of patients is suffering, adults are suffering from diabetes, but less than 1 in 4 people are being adequately treated for the cardiovascular benefit. So this is an important point to understand that 1 in 3 have established cardiovascular disease, and only 1 in 4, only 24%, 25% of patients is receiving the actual treatment in consideration of the cardiovascular benefit. So this is something to ponder about. When we see the prescriptions, we could understand that a small number, less than 10% of population is being treated with SGLT2 inhibitors, which have been proven over a period of time now, 10 to 15 years, that they have cardiovascular benefit, not only in terms of reduction on stroke, the MI, the heart failure, the renal improvement. It's across the molecules. It's a class benefit which we are seeing with SGLT2 inhibitors, but less than 10% of population is yet receiving this particular molecule. And same hold true for GLP-1 receptor agonists, which also have proven their cardiovascular benefit over a period of time now. So this is a pathetic situation. This is a sorry state that despite we having a newer molecule, our patients are not getting the desired molecule for long-term benefit in management of diabetes. If we compare the various guidelines, the European guidelines, the American Diabetic Association guidelines, the European Association of Diabetes, the various guidelines are promoting not only the cardiologists but also the diabetologists about management of newer uses of newer molecules in management of diabetes so as to prevent the cardiovascular complication. This is a Venn diagram which talks about established cardiovascular disease or those who are at high risk of cardiovascular disease, and the uses of these newer molecules, the SGLT2 inhibitors and GLP-1, where GLP-1 is preferred in established atherosclerotic cardiovascular disease, whereas SGLT2 inhibitor is preferred in patients of heart failure and CKD. We also should take into account here that GLP-1 receptor agonist is still in an injectable form and is much costlier in comparison to SGLT2 inhibitors. We in India at least know that our patients are not very much compliant with injectables when it comes to the treatment for a long-term chronic disorders. Sorry. So we should keep this in account that when we are writing a prescription, we must understand the psychology of the patient so that the patient is able to manage his diabetes along with the psychological benefit and durability, not only in terms of the efficacy of the molecule, but also the stability and the patient's continuity towards the treatment is equally important. So we must keep all these things in mind when we are writing a prescription. So coming to the definition in terms of which patient in particular, when we are treating, is at risk for which particular disorder. We have to understand that before writing a prescription. We have to differentiate the patient between the various categories of risk, whether he is at low risk, high risk, moderate risk, or very high risk. And how do we define that? A patient who is young, type 1 diabetes less than 35 years, or a type 2 diabetes less than 50 years, or a patient with a diabetes duration of less than 10 years is said to be in a moderate risk, whereas a patient who is a diabetic high risk. High risk, and those patients with established cardiovascular disease with target organ damage are supposed to be very high risk patients. So we have a category to define according to the European guidelines, latest guideline 2019. How do we differentiate between these patients and those patients who are high risk or established atherosclerotic cardiovascular disease or chronic kidney disease or heart failure? We differentiate between these two patients, and then those patients who have atherosclerotic cardiovascular disease should be preferred for GLP-1 receptor agonists or SGLT2 inhibitors, whereas patients who have established heart failure or CKD should be preferably given SGLT2 inhibitors. We must keep in mind here that compliance with the treatment is very important. If we understand that a patient with established atherosclerotic cardiovascular disease when because of the cost of therapy, then SGLT2 inhibitor is a wonderful choice in the given situation. And guidelines also support this particular thing. Sorry. So we have defined further whether the patient is a drug naive patient, that is newly diagnosed type 2 patient, or he's already receiving some therapy. Once we differentiate that, a patient who is a drug naive patient, we can start with SGLT2 inhibitors or GLP-1 monotherapy. And if we are unable to achieve HbA1c, we can add a second molecule. But if as a patient is a known diabetic and is already on therapy and HbA1c is not under target, we can add various molecules. And we have seen in previous slide that in the given situation, SGLT2 and GLP-1 are the preferred choice. And I understand that SGLT2 inhibitors in Indian scenario seems to be better, probably because of the lesser cost in the present given situation and being oral therapy in comparison to the other molecules. Thiazolidinediones should be given with caution. That patient is not a high risk factor because it is known to cause fluid retention and can cause deterioration. It causes fluid retention and pedal edema, along with osteoporosis, some of the important side effects. Coming to DPP4 inhibitors, it is a good choice when we are using SGLT2 inhibitors as a combination therapy with SGLT2 inhibitor, because a combination of DPP4 and SGLT2 can prevent some of the complications, complications associated with DPP4. That is, we are talking here about urinary tract infection, which is known to occur with SGLT2 inhibitor. So when we are using a combination of SGLT2 and DPP4, that side effect of UTI is being prevented, because DPP4 are known to prevent the bacterial growth which occurs because of the common receptors in those bacteria which cause urinary tract infection. So this is how I would like to differentiate between these four molecules. Going further ahead, we have seen in previous slide, just to reiterate, that lifestyle modification and metformin is a comprehensive management of diabetes. And if atherosclerosis predominates GLP-1 or SGLT2, and in heart failure and CKD, of course, SGLT2 is a preferred choice. And if not controlled, we can go to the next molecules. This holds true in the guidelines also, made the European guidelines, made the ADA guidelines or EASD guidelines. All those are promoting the uses of SGLT2 inhibitors in patients with type 2 diabetes, in heart failure, specifically in patients of reduced ejection fraction, in presence of CKD, because these molecules have shown to be beneficial in terms of improving the renal function, reducing the cardiac load probably, and helping in patients with reduced ejection fraction. Newer studies have also shown that SGLT2 inhibitors, such as the HF study, has shown clearly that SGLT2 inhibitors can be used even in those patients who are non-diabetic and suffering from heart failure, can also be given dapagliflozin. This newer data is a wonderful information to us in managing heart failure without diabetes. Also, DAPA-CKD has shown to be beneficial in patients, even in non-diabetic patients suffering from CKD, can be treated with SGLT2 inhibitors. So this SGLT2 inhibitors has come as a boon in management of diabetes, not only in patients of atherosclerotic disease, the heart failure, the CKD, in all the situations. Of course, we must keep in mind, is there any contraindication, such as if the patient is having CKD and ejection fraction is too less, that is less than 30, then of course we should hold our hand when we are managing diabetes or heart failure with SGLT2 inhibitors. So these patients of diabetes, heart failure with reduced ejection fraction, or CKD with or without diabetes, can be treated with SGLT2 inhibitors for long-term prevention of complications of heart failure and cardiovascular morbidity. The pharmacological therapy in type 2 diabetes, the latest guideline 21 from ADA has also suggested the uses of these molecules in patients of atherosclerotic cardiovascular disease because of its glucose lowering benefit. And this benefit is independent of A1C, that is, whatever the A1C may be, and this molecule can be used. Also, we do not see the complications which we used to see with other molecules such as hypoglycemia is the least known with this. Also, there is a good weight reduction, which is one of the important complications in known complication in diabetes, which leads to insulin resistance. Also, the reduction in cost is one big benefit which has come as a boon in management of diabetes. Also, using these molecules tend to prevent the repeated hospitalization for heart failure, which in itself is a great cost bearing thing. And we know that in India, more than 60% of patients require treat their bear the cost of the treatment themselves. So these all things need to be kept in mind when we are treating a patient of diabetes, heart failure. The things have changed over a period of time. We have understood that this SGLT2 inhibitors is taking care of all the three things: the pumps, pipes, and filters. That is, it is reducing the major adverse cardiovascular events, the hospitalization for heart failure, the renal complications, and this has been published in Lancet. Also, it is helpful not only in primary but also secondary prevention of these diseases. So this is, we are seeing a wonderful benefits of these things. And this is a molecule which, though being talked recently, is actually not new. We have been talking about this since ages. If we try to see, way back in 1835, the fluorescent, which was isolated from bark of apple tree, which was supposed to be promoting the urinary glucose excretion. And then in further study, it also showed that inhibition is it's working by inhibiting the reabsorption of glucose from the renal tubules. This was further proved in mice and then studied in humans. The analogs were developed, and now we have SGLT2 inhibitors, dapagliflozin, as the first approved SGLT2 inhibitors to be used in A1C patients, in diabetic patients. And these benefits are seen across the molecule. But when we see that, what about its selectivity? The selectivity towards SGLT2 inhibitors is different for different molecules. And for SGLT2 inhibitors, it is being used across the globe in managing the diabetes. It is preventing 90% reabsorption of glucose from the proximal tubule of loop of Henle, and therefore preventing the glycemic load into the blood by excreting out the glucose through the urinary tract system and helping in maintaining the glycemic levels. This has all, as we talked earlier, it has shown its benefit across the cardiovascular benefits. Other platelet benefits include benefit in terms of lipid profile, the diastolic and systolic blood pressure. The thrombotic tendency tends to get reduced, the atherogenesis tends to reduce. Therefore, the incidence of MI, the cardiovascular stroke, the peripheral artery disease also reduces. The working on the renal parameters, the glomerular hyperfiltration, all these things also taken into consideration. Prevention of reabsorption of glucose and sodium through the urine helps to reduce the volume loss. It causes the volume loss. Therefore, it takes care of the reduction of preload into the heart, and therefore it is much beneficial in heart failure. And the glomerular stress also tends to reduce due to the hemodynamics of this particular molecule, and this helps in taking care of the renal component of this particular molecule. And these two help each other in improving overall condition of the individual. We know we know that in diabetes there is impaired glucose handling, leading on to the insulin resistance, which increases oxidative stress. There are inflammatory changes leading on to atherosclerosis, hypertension, which reduces the coronary perfusion, leading on to coronary disease. Also, there are fibrotic changes. Therefore, there is hypertrophy and apoptotic changes. All these tend to cause alteration in the metabolism of glucose, the fatty acids, the mitochondrial function, which is occurring in cardiomyocytes, the cardiac cells of the heart, and therefore it affects the diastolic and systolic function, leading on to poor compliance of these components of the ejection fraction of the heart, and therefore it leads to diabetic heart failure. Also, the autonomic dysfunction due to the impaired handling of insulin resistance leads on to the dysfunction of the heart, and this also adds to the diabetic heart failure. And we have just now seen that uses of this molecule tend tends to take care of these things. Heart failure and diabetes are synchronous with each other in a negative way. अन्योनासी संबंध है दोनों में, और जिसके कारण there is more hyperglycemia, there is more insulin resistance, which causes increase in diabetes mellitus. The fasting and ppg increases, the a1c increases, and this leads to the chronic failure, heart failure, which we saw just in the previous slide. And this is a vicious cycle which affects the heart and the kidney functions in an adverse manner. So uses of this SGLT2 inhibitors not only reduces the cardiac load, the preload and afterload, it also therefore reduces the cardiac wall stress and improves the cardiac efficiency and the cardiac output. It also improves the renal function by excreting out the excess sodium, the water, and glucose out of the body. It also improves the clinical outcomes in terms of reducing the cardiovascular outcomes, reduces the hospitalization for heart failure and albuminuria. In the renal function, as we just now said, it reduces the glucose sodium reabsorption. It also decreases, therefore, the intraglomerular pressure. Therefore, the RAS activity is being reduced. There is lesser hyperfiltration and there is less inflammatory changes and hypoxic changes. Therefore, the glycosuria, the diuresis and natriuresis put together improves in circulatory system by reducing the plasma volume, the reduction of the arterial stress, the systolic blood pressure, and improving the hematocrit. So we are seeing a holistic approach in hemodynamics of management with SGLT2 inhibition. The the diabetic patients have shown to progress to heart failure, and by the time we diagnose heart failure, a lot of damage has occurred. Almost 70% of patients suffer from LV dysfunction by the time 5 years of diabetes has crossed, and 40% of patients are diagnosed within 5 years. So most of the patients, almost 100 of patients, earlier or later, shown to be progressing to the heart failure, and it increases the hospitalization for acute emergencies, which is a very cost burdening thing in management of diabetes. The paradigm heart failure study and the TAPA heart failure study both have shown that with normal A1C level but having heart failure can also be given this molecule for their benefit along with the pre-diabetic condition. So overall, diuretics when managing diabetes, but over a period of time with Canvas program, the Declare TIMI, the Empire, all have shown the improvement in subclinical and clinical stages. Also, the newer studies have shown the cardiac improvement in terms of DAPA HF in patients of heart failure with reduced ejection fraction. The Deliver have shown benefit in preserved ejection fraction. So we see the benefit in terms of cardiac parameters across the spectrum when managing diabetes or heart failure. So lifestyle management is of course the mainstay of the treatment, whether it is a new onset or established diabetes, whether the patient is drug naive or the patient is already on some therapy. All these patients should be started with lifestyle modification with metformin, going ahead with GL2 or GLP-1, and we are now not restricting ourselves only to the A1C level, but if A1C is not achieved, we can add DPP4 inhibitors. After that, we have to see what is the patient condition and accordingly choose what should be the molecule. If we are seeing long-term beta preservation, we should avoid molecules like sulfonylureas. The pioglitazone should be is a wonderful insulin sensitizer, but when it comes to conditions like weight or heart failure or fluid retention, we should think twice before using pioglitazone. Alpha glucosidase inhibitors is one molecule which inhibits the absorption of the glucose through the GI system and can be helpful in some of the patients. So when we are managing diabetes in this way, we are able to benefit the patient in terms of his stroke, MI, heart failure, diabetic retinopathy, nephropathy, neuropathy. Overall, there is a wonderful benefit in managing the diabetes. The A1C reduction has been shown across the molecules, whether it is CANA, DAPA, or EMPA, and this is quite significant. So, GLP-1 and SGL2 both have shown wonderful benefits in management of diabetes by taking care of the decrease in appetite, the glucose-dependent insulin secretion, reduction in blood pressure, natriuresis, reducing inflammation, slowing down gastric emptying, and then promoting the urinary glucose excretion. So we have totality of benefit. Probably we are taking care of the all the components of amino octave which is associated with management of diabetes. So GLP-1 and SGLT2 both have shown their benefit in their own way in management of diabetes, which we have been seeing in the last few slides. Once again, to reiterate that SGLT2 inhibitors, by promoting glucosuria, reduces the A1C, weight and blood pressure, and GLP takes care of reduction in A1C and weight. Though it is not much beneficial in terms of blood pressure, but it decreases the glucagon secretion and takes care of the appetite. So these are some of the properties of GLP-1. So how do we decide? Once again, our initial slide, that atherosclerotic disease or heart failure, metformin monotherapy, drug name. So once again, I would like to say that if we have any comorbid condition, we should begin with SGLT2 or GLP-1 in drug naive patient, and we must keep in mind that whether our patient can afford costly molecules, or he's ready to accept the injectables. So taking everything into consideration, we should opt our treatment profile for the patient and choose the molecule accordingly, so that patient can maintain the treatment for a long period of time without breaking his treatment. And also we should understand that this molecule should take care of his long-term complications which might occur with diabetes, that is heart failure, CKD, the micro and macrovascular complications. So what are the things which we should keep in mind when we are prescribing SGLT2 inhibitors? We must understand that when we are using this particular molecule, we may need to reduce the doses of diuretics, maybe loop diuretics or thiazide type diuretics. It should not cause hypotension. It may increase thirst. So patient must be prescribed that for the appropriate benefit of this particular molecule, he should have sufficient intake of water. Diuresis also increases the glucose levels in the urine, but 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 that should be kept in mind when a urine analysis is done, and should not be a panicking thing when a urine report shows higher glucose levels and a patient is on SGLT2 inhibitors. Also, there is a consistent reduction in weight, and there is also benefit in terms of creatinine levels in long term. Maybe there is a little bit rise in creatinine in initial stage, probably because of the adaptation which takes little time. Genital infections may occur in some of the patients, and for that it is a good idea that patients should maintain local hygiene, and good water intake is important when SGLT2 inhibitors is being prescribed. Also, DPP4 can be combined to prevent SGLT2 inhibitor induced urinary tract infection. We need to be little cautious if the patient is a known patient of, or a history of ketoacidosis is there, or there is some ongoing ulcer or some history of amputation, or if there is any dehydration or some surgical emergency, then probably we should not use or stop SGLT2 inhibitors. In type 1 diabetes, there is a higher risk of ketoacidosis. Therefore, SGLT2 inhibitors should not be used as of now. Pulmonary gangrene is known in some of the patients, or there is some increased risk of amputation in some of the studies, but they have been passed in future in further studies. So that is a little bit doubtful thing. though an ongoing amputation or ongoing ulcer should be in such patients, it should be avoided by SGLT2 inhibitors. So it's a good idea to use these molecules in type 2 isolated patients with ischemic heart disease, with heart failure, with stroke, with these molecules are to be used for long-term benefit. Genital infections, some of the adverse effects which we just talked. Genital infections little more common in women or uncircumcised men, and for that we have already talked that a good fluid intake and DPP-4 inhibitor combination can be taken care of. Hypoglycemia is a rare thing. Diabetic ketoacidosis once again occurs due to the less water intake. So if you are able to maintain good good hydration, probably this can be taken care of. Amputation is not very common. It was observed with some of the patients in some of the trials with canagliflozin, but further studies have quashed this thing, and it was found to be as prevalent in placebo management of placebo management of diabetes also. So overall, we can understand that the management of diabetes in recent few years has changed from just the numbers of fasting ppg and HbA1c to the holistic approach of the patient, which should slow the progress at least in terms of cardiovascular and renal safety and heart failure. So to conclude, I must say that trials have supported that SGLT2 inhibitors are beneficial in atherosclerotic disease in diabetic or non-diabetic patients, and benefits are far, far, far better than the so-called adverse effects. Also, the various guidelines have suggested the use of these molecules in most of the patients. We have so many pleiotropic benefits, these particular molecules, and it is not only the diabetology, but also the cardiologists are using this molecule in management of their patients. With that, I would like to thank you for your patient listening, and we must use the newer molecules for the best treatment of the patient, and we should not be afraid in using these molecules. Thank you so much for your patient listening. Any questions? Most welcome.
So thank you very much, sir. It was such a lucid and informative presentation. I would request all the attendees and delegates, if you have any query, you can raise your query through chat box, or you can also raise your hand so that we can draft you into this live webinar. Sir, we already have 4 questions. I'll just read for you, sir.
Sure.
One question is from Dr. J. Tripathi. Sir is asking, what is the maximum dose of SGLT2 blocker in heart failure?
The doses of SGLT2 inhibitors is same whether in heart failure or diabetes. If we talk of dapagliflozin, we can go a maximum of 10 milligrams per day per 24 hours while managing heart failure patients. And that holds true even for diabetic patients. But we must ensure good hydration, and some of the side effects which we see, the commonest being the urinary tract infection, that should be taken into account, and that can be very easily tackled with good local hygiene.
Thank you, sir. So second question is from Dr. Vikas. Can SGLT2 inhibitors be prescribed with diuretics?
Yes, it can be prescribed with the diuretics, but we must understand that when we are using these two molecules together, then probably we may need to reduce the dose of diuretics because SGLT2 inhibitors in itself promotes diuresis. This is the basic mechanism of SGLT2 inhibitors, and probably because of this only, it is being beneficial in patients of heart failure. So we should reduce the dose of diuretics when we are using it combination.
Thank you, sir. Sir, third question is from Dr. Lahiri. What precautions to be taken while using SGLT2 inhibitors, especially in old-aged diabetic patients?
Practically, there is no special precaution which has to be taken, except for one which I would like to reiterate, that is urinary tract infection, which we know that's a little more common in females and in older age. So local hygiene, if we are trying to maintain, that should take care of the complications associated. Otherwise, practically speaking, no other complication is being seen in this particular molecule. And if that becomes a concern, then addition of DPP-4 can be taken into account to prevent this complication of UTI.
Okay, sir. Sir, one more question has come. What drugs and food should we avoid while taking this DAPA?
practically there is no restriction in food when we are talking of this molecule. It is the basically the management of diabetes. If we are using DAPA in diabetic patient, then the diet which we are advising for diabetic patient, practically if we think, see, only three restrictions are there. किसी भी तरह का मीठा मत खाइए, किसी भी तरह का बाजार की बनी हुई चीजें, फास्ट फूड, पैक्ड फूड, जंक फूड, ये सब मत खाइए, और नॉन वेज अवॉइड कीजिए। इसके अलावा मुझे नहीं लगता डायबिटीज में और भी कोई रिस्ट्रिक्शन की आवश्यकता है। एंड इफ वी आर टेकिंग केयर ऑफ दीज थ्री थिंग्स, probably we are managing the diet of a diabetic patient, and that should be sufficient while using this particular molecule. And if we are not taking care of the diet, what matter treatment you give for diabetes management is not going to be resolved.
Thank you, sir. I request all the doctors, delegates, if you have any queries, either you can raise your hands or you can put your raise your queries in chat box. Sir, we'll wait for 1 or 2 minutes.
Sure, sure.
I once again request, if any queries are there, kindly raise your queries in chat box, or you can also raise your hands. Fine, sir. It seems there are no more questions. So, with your permission, now we can conclude, sir. First of all, sir, on your behalf, I would like to thank all those 40 doctors who have joined today. In fact, sir, 42 doctors joined today. So, on behalf of Dr. V K Jagnany, I would thank all of you who have spared your valuable time. And sir, on behalf of JV Chemicals and family, sir, we must thank you, sir, for such a lucid and wonderful presentation. So it was very insightful, and I am sure whomsoever has joined today, they must have been benefited with the knowledge. So once again, thank you, sir.
Thank you so much, JV Chemicals, for organizing this CME. Thank you, Santoshji. Thank you, Kunalji. I would also like to thank all the delegates who have attended the conference. Thank you so much. Take your leave.
Thank you. Yes, thank you, sir.
Okay.